I mean, take an astronaut, for instance, okay? If they're up in space 3 to 6 months, they come back and their bone density's decreased by, I'm making this up, 50%. It's known when they're stepping off the space shuttle, they can have an acute fracture just because their bone densities. So the only way to do that is to put energy into a biologic system. We're the perfect way to put energy into a biologic system. So if conceptually, if you could use this in space, the astronauts could come back with higher bone density than when they left.
Welcome to the Longevity Formula with Dr. Brandon Crawford. Let's explore the new era of wellness.
Hey everyone, welcome back to the podcast. Today we're going to be diving into some really groundbreaking technology. I've got John Warlick here joining us today, the brain behind this technology that we're going to be talking about. We're really going to be exploring something called Softwave. The Softwave technology was something that my medical director, Dr. Madera, actually brought to my attention. She said, hey, Brandon, we're using this in various ways, mainly in regards to stem cells. And she said, with your demographic of patients, with everything that you guys are doing, you really need to look at this. So I did, and I'm always really cautious and usually pretty methodical about how I review things. But this technology was something that I decided to quickly adopt. So I actually did review tons and tons of research. And that's the great thing, is that there is tons of research behind this technology. So I was really readily able to quickly ascertain that this was absolutely something that could benefit not just my patients, but myself, my family, everyone around me. So John, Mr. Warlick, thank you so much for joining us today.
No, I'm glad to be here. Thank you for the invitation.
Absolutely. So I think the first thing to understand is, really who you are, where'd you come from, why are you here, what's going on? So if you don't mind, if we could get a little bit of background on you. You're not a clinician, right? But you've really spent a large part of your life developing this technology. Can you give me a little bit of background on yourself, please?
Yeah, our legal team will make me give a 30-second disclaimer. I mean, we are very cautious with the FDA, but we have multiple FDA clearances, and they happen to be for acute and chronic wounds. They happen to be for connective tissue activation. And most people would ask you what that means. And when I asked the FDA what that means, and we got our first FDA clearance, they said, don't ask. But it seems very important. That was our first FDA clearance. We also have it for blood supply and for pain as well. We have a half dozen other indications in the pipeline, including ED for non-healing bones. A really exciting one is about to be FDA approved, our first FDA approval through an affiliate of ours, Dr. Tom Liu in San Francisco at UCSF, and that will be for stress incontinence. He showed a dramatic reduction in leakage at 16 weeks in a clinical trial that had 20 of the most prestigious U.S. medical centers. And then also, so a lot of stuff we're talking about, although there's a ton of research on it, we may or may not have FDA clearances. However, that connective tissue activation gives us a lot of leeway as well as pain and blood supply. Those are the most frequently used clearances when we're doing our research.
Sure. That makes sense. And I definitely understand the whole FDA navigation, not to the same degree that you do, but with our, lasers that we've developed, we've had to really navigate that. We're still navigating it. And, it's kind of a bit of a mess, kind of a game that you got to play in that FDA world. So I totally understand that. And a lot of what we're going to talk about may be off-label use. So just so the listeners understand that, I am, like I said, Dr. Madera, she is a clinician. So clinicians are allowed to use things off-label in various ways. So a lot of the discussion may revolve around that. So absolutely.
And a lot of things, internationally, we have a whole lot more clearances and approvals than we do here in the States. Just the Europeans have been using this standard of care for 30 years. So literally tens of thousands, not hundreds of thousands of cases for each of these indications we're discussing. However, just not yet possibly cleared in the U.S., but we will be pursuing the vast majority of the things that we're talking about.
Absolutely. So going back to who you are. So who are you, man? Where'd you come from? Why are you here?
Wow, that's a tough one. I think you gave me a couple questions introductory. The first thing was initially, how did you get involved? How did you get involved in Shockwaves? And the simple answer was vacation. I was working for Lockheed selling spare parts. I sold the $200,000 coffee pot. I sold the $20,000 hammer. I was selling spare parts, first job out of college. And that was a great job preparing you for medical technology, because when I went looking for my second job, Dornier Medical Systems, which was the founder, everything we're talking about all goes back to Dornier. All this goes back to shockwaves for kidney lithotripsy. That was the first shockwave use in the United States. However, leaving Lockheed at the time selling spare parts, I went looking for a job because in 3 years I never had 1 week of vacation. Dornier was advertising 6 weeks of paid vacation in year one, plus every known holiday that you can ever imagine, some you've never heard of. So that attracted me as a young man, and I essentially, in 1987, they had an office with about 10 people here in Marietta, Georgia. They had just got FDA approval for the kidney lithotripter. It was about a $3 million device that took up a room, 3 rooms the size of my office here. It actually had a bathtub where you had to submerge the patient, and then a high energy shockwave device that you would target a patient's concrement, their kidney stone, and you would dissolve it after about 3,000 shocks into sand, and you would pass it in your urine. But everything that we're talking about today goes back to that. And so I was with Dornier for about 3 years, and after 3 years, I learned that the Germans aren't very good at customer service, so I lost my first competitive company, and I've been in shockwaves ever since with my own technologies. I did take one company public, which was Healthtronics in the 1990s. We got the first FDA approval for a non-kidney stone related product. And that was for the Oscitron. And we got it. It was a kidney stone like machine using high energy shockwaves to treat plantar fasciitis, as well as the tennis elbow and golfer's elbow, all the tendinopathies. So I've been pursuing this ever since, but every bit of research can all go back, and we're be thankful for Dornier for starting this whole technology back in 1987.
That's great. And when did you actually get involved with Softwave rather than Shockwave? Because we're going to get into some differences in that, so we may not want to do that now, but I'm just trying to get the progression of like how you got here with this amazing technology.
Well, what we discovered in 2004 was really the breakthrough. I mean, in 1987, we knew high energy shockwaves would destroy a concrement. In about 1986, before even offering that the first time, Dornier, because essentially we had an ellipsoid about this big in a shockwave that focused about 16 centimeters in the body. So it's this huge fixed ellipsoid. But somewhere in that pattern, your ribs and pelvis were going to be, and they were concerned that if a shockwave was destroying a concrement, what would it do to a bone? Because some of it was passing through the bones. They were worried about that and thought that might be, prevent them from selling the device for safety issues. But they designed a study to target bone with high energy shockwaves. We're talking about shockwaves 30 times higher than the levels that we're using with Softwave. But the first time the aha moment happened is after this study, at about 6 weeks, they noticed that the iliac crest was thickening in the bone that they had targeted. And they also noticed that the bone densities were increasing dramatically. So that was the first time that somebody noticed a biologic effect with the use of shockwaves. And so they saw that it wasn't a problem. It wasn't going to be breaking the bone. It wasn't going to be causing fractures. And so that gave them clearance and the comfort to start offering that in the United States for kidney stones. But that was a very breakthrough moment, because that's the first time somebody got there might be a biologic effect associated with shockwaves. But the difference being from 1987 until 2004, when we formed, there are about 20 companies pursuing shockwaves. Dornier evolved into Siemens, into EDAP, into Medstone. There's 20, 30 companies, Wolf, Storz. And up until 2004, everybody thought that the mechanism of action was trauma, because that's what we were associating with kidney stones. We realized that when we were targeting the plantar fasciitis, we thought we were breaking up the calcium deposits. We thought by breaking up the calcium deposit, they were causing the pain, and that it would be almost like a kidney stone-like response. But we found out very quickly that when you targeted the plantar fasciitis with a high-energy shockwave under anesthesia, because it's so painful, although it was amazingly effective, on day one, the pain was going away. But if you looked at the x-ray, the calcification was unchanged. But then, so that's the light bulb went off. What's going on here? It's not what we think. But up until 2004, everybody thought the mechanism of action for even non-kidney stone related pathologies was based on cellular destruction and trauma. We thought it was the hot poker theory in surgery. We thought that non-invasively we are causing microfractures and microbleedings, and the body had a neovascular response to that. But only in 2004, after I came out of retirement for 5 years after selling Healthtronics and after it went public, we had discovered in that interim window that you did not have to cause cellular trauma to have a biologic effect. Dr. Wolfgang Schaden, our medical director from Vienna, Austria, he discovered in that 4-year window while he was treating osteomyelitis patients, they had non-healing fractures, like a tibial non-healing fracture, and they had like a skin defect associated with that. And he was treating that with high energy shock waves, and he realized that the skin defects were going away, the wounds were going away, they'd been there for years and years. And the light bulb went off and said, these skin defects are being treated in the unfocused, low energy portion of the shock wave. Maybe our mechanism of action is not what we thought it was, because the skin defects were healing within days, even after having been there for years and years. And then also the non-healing fracture would go on to healing at 12 weeks. But almost immediately he would see the wound become disinfected. He'd see the wound become pink and healthy, and in weeks it'd be perfectly healed. So then he hypothesized that it was not requiring a traumatic effect. He recruited me out of retirement. We got together our old medical team that had formerly been with Healthtronics. We brought them all back together, and we started this company called Softwave TRT. And it was predicated on the hypothesis that you do not need high energy focused shockwaves that are painful and destructive to have a biological response. It was beautiful because he's working with the Austrian government, and they're essentially a single payer healthcare system over there. And they have a law that says the most expensive pathologies have to have research associated with them. So as an insurance company, it's like Blue Cross Blue Shield trying to find the cure for spine trauma and brain trauma. They do it because it saves lives and money, and because they're the single payer. So they want to know how we can help reduce these pathologies, make the patients better faster.
Nice.
So he had access to all of that research team. So he very quickly started doing all the basic research. And very quickly, we proved that you did not have to cause a traumatic response to have a biologic response. The shockwave itself was putting shearing forces on the cell wall. It was compressing a cell, then expanding. And essentially, the exosomes were cascaded in the extracellular network. There's microvesicles are shedded. Essentially, we're fooling the body into thinking it was injured with the shockwave itself. It did not require a high-energy focused shockwave that's painful and destructive. Everybody else until 2004 and even now, they're using an ellipsoidal reflector so that all this energy goes to a spot. You put the pathology in that spot, trying to cause microtraumas. Yes, that works, except it's painful, traumatic. It's one step back, two step forward. By making a parabolic reflector, the same amount of energy or less is spread over a much wider area. It's almost painless or much less painful, and you can treat larger areas faster, and you're not causing cellular destruction or death. Our box has been tuned down to a level of 0.2 millijoules or less, and it's impossible to cause cellular trauma at that level. Anything higher than 0.24, you can cause cellular trauma and death, and all the other technologies are relying on the mechanism of cellular destruction, one step back, two step forward, where we just learned it's a biologic. We fool the body. That shockwave itself puts shearing forces on the cell wall. The cell thinks it's been injured, and it starts a biologic cascade. Essentially, the same thing that happens when a body's injured naturally. We're just extending that by another 12 weeks, essentially.
Can you actually do us a favor? Can you tell us what exactly a shockwave is?
Well, this whole industry's sound waves, okay? Even ultrasounds gets looped into this universe of sound waves. We all know they're continuous waves like this, and they generate heat, which is good and bad. But shock waves of this whole universe are a tiny little slice, and they reach a certain definition, primarily about the speed of sound, and reaching certain peak pressures very, very quickly over time and dropping off dramatically. We're talking about millions of seconds. So there's a very technical definition of what a shock wave is, but of this entire globe universe, a shock wave is a tiny little wedge of the sound wave universe, and soft waves is a tiny little wedge of the shock wave universe. That makes us unique. But primarily it's about the peak densities of the pressure and the sound at which the sound travels. But it's a very technical definition, but everybody loves to call themselves shockwaves because there's a lot of great shockwave research, but they're really just sound wave machines trying to catch the coattails of the very specific shockwave definition.
Gotcha. Okay. Well, that makes sense. Thank you for that explanation.
Yeah, I mean, as you see in a shockwave, have you ever seen I can send a picture of it to you. There's a jet as it passes through the sound barrier.
Yeah.
It causes an expanding plasma bubble. That's a shockwave.
That's what it is.
It's a very visual response of what a shockwave is.
So that's literally, so if you, because I that gave me a really good visual actually. So if you can imagine.
When the plane passes through the speed, our medical director he's a backseater of that, was it F-16s, the two-seaters? He said when you pass the speed, you could actually see that plasma bubble come off the jet.
Oh, that's cool.
Really cool. That's a shockwave.
Wow. Okay.
And that's a lot of energy. It's moving really fast, and it has certain, physical densities and capabilities. But that's it. Just look at it. And also, it's thunder and lightning. I mean, there's certain things that are shockwaves and certain things that are not. So the most visual is a jet passing through the sound barrier creates a shockwave. Very visual, very dramatic.
I have a patient from Australia that when we would use the Softwave on her, she would say, it's the thunder and lightning. So we actually call it the thunder and lightning now. So
I like it. I mean, if you go back to old timers over in Europe, for instance, they would only pick mushrooms, or the best time to get, is after a thunderstorm. Okay. Thunder does things. I mean, there is a physics to it, that it makes things grow. It makes things happen. I mean, it's true. It's not this old wives' tales, but thunder is very beneficial.
Yep. Awesome. So then to take that conversation a little bit further, so you get this shockwave, produced, this plasma bubble, et cetera, right? So when that hits the tissue, how is that shockwave actually is it just going straight into the tissue? Is it being converted to something else? Like, how does that actually?
Well, the mechanism of action, if you wanted to study what how do you translate biologic energy, physical energy into a biologic response, is mechanotransduction.
Gotcha.
The mechanism of action that you can pull up a nice little screen that has a beautiful, I could never explain it, but this is mechanotransduction. It's converting energy into a biologic, in the biologic system.
Okay.
And most times pathology or disease states, it's lack of energy. I mean, we're just putting energy into a biologic system. It's just an efficient way to do it.
Gotcha.
I mean, it's like we take an astronaut, for instance, okay? If they're up in space 3 to 6 months, they come back and their bone densities decreased by, I'm making this up, 50%. It's known when they're stepping off the space shuttle, they can have an acute fracture just because their bone densities, okay? So the only way to do that is to put energy into a biologic system. That's about all those vibrating plates. We're the perfect way to put energy into a biologic system. So if conceptually, if you could use this in space, the astronauts could come back with higher bone density than when they left.
Wow.
Okay? Because you get enough energy into a biologic system that it maintains the mass. So that's all we're doing. And as you get older, the less energy is being, you're not walking as much, you're not making contact. So we're just putting energy into a biologic system in a very efficient fashion.
So literally the discussion around E equals MC squared, energy equals mass times the speed of light squared. So you're actually having an influence on both the energy side and the light side, right? Because my big thing is, you in order to change matter or mass and or energy, it's a light discussion, right? So we control light and we influence different wavelengths of light, but then also the timing of the light and all these different things. So you actually have light, but then you're also creating this plasma bubble, which is on the energy side. So you're influencing this equation at two sides, if I'm understanding correctly.
Boy, you just went way over my head. Yes.
That's a cool discussion.
I was there, but yes,
That's cool. That's cool. That's amazing.
I should be interviewing you next time. You're smarter than I am.
So I'll be honest, whenever, this was first brought to me, right? And the first mention of shockwave really shut me down because I had, I'll just say, an aggressive salesperson back in, several years ago come in, not associated with you guys at all. This was a whole nother company purely just selling the mechanical shockwave devices, right? And they came in, they're like, we're going to cure everything under the sun. Give me anything that hurts on you right now and I'm going to make it feel better. And I was like, all right. And he starts hammering, with this thing. And I say hammering because it was like, bam, 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 bam. It was intense. And I wasn't even that hurt. But when he started using that on me, I wanted to punch this guy in the face. It was painful. And I was like, stop. And he was like, no, it has to hurt like this so it heals faster. And I was like, just shut this down. Get out of here. I'm not going to torture my patients. Like, get out of here. And so that was my first and only experience with Shockwave up until that point in time. But I say that because this is really going along with what you're bringing to the table now, is that it's not just about that trauma component. There's so much more going on, and that's what Softwave is leveraging. And that really is what got me super intrigued, is that this does not have to hurt in order to get the type of responses that you want to get. So if it's not the trauma response, I understand we're somewhat fooling the body into thinking, there was an injury and that's setting in motion this cascade of healing events. But there's so much more going on there, right, with Softwave. And I guess it goes back to, really, I guess we could have a discussion about like what's really causing pain, dysfunction, underlying health conditions or diseases or whatever. And I think a lot of that can be, tied back into inflammation. I mean, we can talk about blood flow, we can talk about so many different things, but if we really want to talk about, what's driving a lot of this, it would be the inflammatory response, specifically the chronic inflammatory responses, right? In my world, we talk a lot about photons, electrons, and frequencies. And another thing that I was really intrigued about Softwave is that there's actually a light component. So I was very, very intrigued at how you're producing the shockwave by using light that then transfers into sound. And then that energy is, pushed into the body that way. So I know that you gave me an acronym the other day and it was HEAL, HEAL. What did that stand for again? Can you walk us through that?
Well, it's sometimes it's a little bit corny, but it's true. It's we produce four kinds of energy. There's a heat component, there's an electromagnetic pulse, which is usually beneficial, as you see from all these PEMF devices. Then also we have the acoustic component, which is, we believe, the most important component, but also there's light. So if you just take the first letter of all that, I think I found it, it stumbled on me. We actually trademarked it. It's so heat, electromagnetic, acoustic, light. If you take it, add up to HEAL. But those are all four types of energy that we produce, whereas the PEMF device only has an electromagnetic component. And a lot of these other technologies have one or two, but our technology is unique and that we have all four of those types of energy. And and all four play a vital role in healing. I can't make a living saying light doesn't work or acoustic doesn't work myself or PEMF. They all are useful, but we just have the benefit of they're all in one package. We have a huge electromagnetic pulse. I mean, we underestimate the value of that because when we did our first FDA study for the oscillotron, when we had to do it randomized controlled, we only shielded and blinded the component to the acoustic energy. We put some styrofoam over the bellows and the patient couldn't see it. So we treated the patient, but we had these, even with non-healing fractures, 20 years old, we were getting in the placebo group, we were getting like 40% healing. In the shockwave group, we were getting 75% healing, but we had projected 5% for the placebo group because they're 20-year non-healing fractures. They're not going to get better. But what we didn't realize is we weren't blinding for the electromagnetic pulse that we did. And so it made our study went a whole lot longer because we didn't randomize correctly for the number of patients. But at the end of the day, we got, we proved in a randomized controlled fashion that we have a dramatic improvement for bone healing. But we also proved that electromagnetic pulse, as we all know, also is hugely beneficial for that. So it's a nice little package that we just got lucky. We didn't know this when we started the technology, but we've now stumbled on the fact that all four of those energies are beneficial.
Yeah, well, and I've definitely felt it. I mean, it's quite amazing. I'm going to go into some of my experiences here in a little bit, but before that, we've talked about how amazing this technology is and how it differs. But can you walk us through, because when you look at it, I'm sure people are going to go online at softwavetrt.com. They're going to, and I got that website right, correct?
Absolutely.
Softwavetrt.com. They're going to look at it and be like, what the heck is going on here? So if you could walk us through, so there's a generation of plasma, right? And then that's transferred through some fluid. And then can you walk us through like how this is so, just the technology itself?
Yeah, there's several different types of shockwaves, okay? And we got lucky. We weren't smart back in 2004. We got lucky. This whole, our business, we got really lucky. Because one, we picked the most expensive shockwave technology in the world to make. It's the most expensive, but that's what we did back then. We knew it was better, but we didn't know that all the advantages of it. But we essentially, underwater, we evaporate two electrode tips, almost like automotive electrode spark plugs, surrounded by fluid. We discharge it up to 20,000 volts across the gap. It evaporates a small amount of water very quickly, causes an expanding plasma bubble. On the leading edge of the plasma bubble, what also makes us unique is that this essentially is a shockwave, okay? And it's in a millionth of a second is passing through the cells. And what it does is put shearing forces, put compressive forces, and expands. But the other beautiful thing that we did that 90% of the other shockwave companies don't do, we put it with a lens so that every bit of energy that we discharge can be pushed in one direction. 90% of people call these things radial ballistic devices. They're two metal pistons that bang together, and they cause a pressure wave, not a shock wave on the skin surface, but it goes spherically in 360 degrees. And so only that tiny bit of energy that's pointed at the pathology is beneficial, and you're wasting about 99.9% of energy. So you have to, almost like a mini stick of dynamite on the skin surface to get enough of that sphere directed in the right direction to have a beneficial biologic response. But because we chose a parabolic reflector, every bit of energy can get pushed in one direction. But it's all about the plasma bubble, the leading edge of the shock wave that you can shape with the lens, and literally like a millionth of a second, it passes through the cell wall, causing, fooling the body and things have been injured and starting a biologic cascade.
And what I was reading is that this has been measured to go up to 12 centimeters into the body. Is that right? Or did I get that wrong?
That's probably the number. I'm probably the most guilty person in the world of that, because we always talk about depth of penetration. Mm-hmm. And we were always saying we have more than they have, but that's really not true. I mean, I have to throw ourselves, call a red flag on ourselves. Every shock wave or even sound wave, regardless of how weak it is, passes through the body, hits air, turns around, and comes back. Okay. So every shock wave goes all the way until it hits air and comes back. The key about when you're talking about depth of penetration or penetration depth is having enough energy at depth to have a biologic response. Yeah. All of these 95% of machines sold out there very inexpensively are ballistic radial type devices. They're massagers essentially. But even though they generate a huge amount of energy on the skin surface, which is very painful, at 1 centimeter, anything after 1 centimeter, they don't have enough energy to have a biologic effect. Okay, but the key is by having the lens and electrohydraulic, which is a much more efficient form of the shock wave, we have enough energy at 12 and 14 centimeters to have a biologic effect. The only reason you turn up the energy level to higher levels is so you have more energy at depth. Even at our lowest energy levels, that shock wave goes all the way through the body, turns around, and comes back. So that's just one. We're guilty of mischaracterizing that as well. But a shock wave will go all the way through, but the key is having enough energy at depth to have that biological.
Gotcha. And that's the same thing with light. Like that's the same thing that we understand with photobiomodulation, and that there's primary, secondary, tertiary, like there's all these different types of effects. It's a cascade response, right? That you're setting into motion a whole series of events that may even transfer through the entire body. In photobiomodulation, we even have studies where you laser the hindquarters. I forget the animal. I don't know if it was a rat or what it was, but they lasered the hindquarters and they had changes in the blood-brain barrier in the brain. So we know that, we can set in motion different biological responses that can have a full systemic response. But a lot of times in research, they like to really just quote that primary effect, which, maybe that goes 1 centimeter, 10 millimeters, however we want to talk about it like that. So I definitely, am privy to that and understand. I would love the conversation around plasma. We didn't talk about this before, but plasma is something that really, really intrigues me. I love that your device does produce this plasma. Plasma in and of itself has this intelligence in it. Plasma is what makes up, from what I've read, from what the, physics people know, the majority of our universe. And it's very interesting how plasma can actually interact with the body. And now we're actually understanding that a lot of the cell-to-cell communication is actually plasma related. So this is like some of the leading research right now. So I think it's really interesting that your modality produces this plasma effect. And I'm not going to say that, you're shooting plasma to people. That's not what I'm saying.
No, but it's interesting though, because 2 years ago, we never would have mentioned it. However, what you just said, 3 years from now, we might coming back and saying, what were we thinking about sound waves that all was about the plasma? Right. It's funny how we've evolved. Our descriptions of the mechanism of action are still evolving. 3 years ago, all we focused on was stem cells. 2 years, all we focused on was exosomes. And last year, the new phraseology is microvesicles and shedding. And right. It'll change next year because we know it works, but describing how it works is still a work in process. Yeah. And we will be learning for the rest of my life.
Yep. And that's how when you're on the leading edge, right? And that I think that's important for listeners understand. And that's really what we're trying to do is we want to talk with the people at the leading edge, and we have to be okay with the science and the knowledge evolving if you're at the leading edge. And so, I applaud that. I think it's fantastic that you guys are open to those conversations and willing to listen to the new information coming out. It's quite amazing.
Probably the one other I probably should have put back. I mean, the most exciting thing about our technology is we've been doing this since 1987. Okay, at energy levels at least 10 times higher, typically 30 to 50 times higher. A focused shockwave in the kidney, and we're averaging about 300,000 to 500,000 treatments in the U.S. alone since 1987. And every one of those treatments, you're treating an internal organ at incredibly high energy levels. And you could put an ice cube in a focal point, and it would shatter the ice cube. Okay.
Wow.
And however, we've been doing that, and every time you're doing it, you're treating large blood vessels, you're treating nerves, you're treating skin, you're treating everything, and nothing bad has ever happened.
Yeah.
So the most beautiful thing about a shockwave, now, divide that by 30, and it's the most important thing is do no harm. It's really inconceivable of how you could hurt something short of dropping the 50-pound box on your toe.
Right.
And the good news is if you do that, we can fix it. We make broken bones go away. So the reason I have a certain comfort level talking about these things is that we know from years and years of experience and tens, if not hundreds of millions of treatments, that it's a do no harm technology. So sometimes we sound a little bit cavalier about doing some of these things. This because everything we mentioned here has been treated in a certain patient cohort somewhere in the world, and they're comfortable talking about it. In the States, we're regulated by the FDA as we should be, but it's important to know is do no harm. That's the most important part of these discussions is it's really hard to hurt yourself with shockwaves as generically and more specifically Softwave, which is a tiny little wedge of the shockwave family.
Yeah. Well, I definitely know it works. I mean, my own personal experience, so I've actually had 2 back surgeries. I do have a torn meniscus. I have a torn MCL as well in my knee. Obviously, I'm a laser guy, so I use lasers. I do things like cold thermogenesis or cold plunges. I do various types of things to keep myself working. And I've never had a knee surgery, but I have had 2 back surgeries. I actually had my wife use the Softwave on my back. And I will tell you, I have never actually felt that much relief. It was like I had better mobility. The pain was like non-existent. I typically have this like area kind of around the right shoulder blade area that just feels like someone's stabbing me in the back. That was completely gone. And the weird thing is it's like one of those pains that I just was used to. I just walked around with it. I didn't even really realize it. But what was really interesting to me, I like to run. And so when I go for a run, I'll usually run about 4 miles. My pace, depending on how I feel, is usually around 10 and a half minutes a mile to around 11 and a half minutes a mile. I'm not running a race. I'm just running for fun. After my wife did this to my back later that day when I ran at a 9.5 minute per mile pace. And I was like, that's cool. I mean, I don't typically run that fast, but it was just a good day or whatever. And so fast forward, she did it again. And this was, I don't know, maybe a few weeks later. Same thing happened, right? So she did that treatment on my back. That day, again, I ran faster. I was like, wow, because we've had conversations about how this could be like the ultimate biohack, And that's one thing that I really want to do is I want to develop like a biohacking strategy with this too, not just for pathology, but how we can, stay optimized and really keep our body healthy and functioning best we can. And then my knee too, right? I would usually when I start running, I really have to push through the pain with my knee. And after about half mile to a mile, I'm good. But if I Softwave just right out of the gates, my knee is good. And I don't struggle with any kind of knee pain afterwards either. So that was me personally. My youngest son, actually, he'll get a migraine from time to time. And he actually came home. He came to my office. My wife had to go pick him up from school. And he was, had a migraine. And I said, well, typically, we would put him on lasers. We would do vagus nerve stimulus. We would do these things. And that helps. But I thought, well, let's try the Softwave. Did the Softwave and it was immediately gone. His migraine literally.
Where'd you apply it?
I'm sorry?
Where'd you apply this
So
Softwave?
he gets this migrine behind his left eye. So I literally just did that left frontal lobe area.
Did you really? Okay.
And
the other way, most frequently it's applied. They will apply it there because people are. They shouldn't. Well, because of the FDA, maybe they should be. But very frequently for migraines, it's at the base of the skull. But in vasodilation, it seems to, there's a lot of reports. I've seen papers on that. So that's very interesting. And then also, if you really want to go out there, we've seen some really cool case reports for migraines. If you're trained in Eastern medicine and believe, which I do, in reflexology, replacing the reflexology, the pressure points, the manual pressure points with soft waves, we've seen some amazing relief by treating the fingertips for the brain as well.
So okay. So I wasn't going to talk about this, but you bring that up.
Yeah, it makes me sound crazy.
No, that's really good. So we do a lot of primitive reflex work in our office, right? So we're working on developing the brain growth and maturation. A lot of that means we have to, work on primitive reflexes. And so what we're doing now, right? So this is just some work that we're trialing. We're doing some pilot studies and whatnot. But basically, if you have the sensory motor loop that develops the brain, well, my whole thing is, okay, if we can put energy into that to help convert muscle spindles faster, we'll develop the brain faster. And so now what we're doing is we're using the Softwave, almost like we're using our laser at times, as an adjuvant to actually increase the muscle spindle conversion to actually integrate primitive reflexes faster. So far, we are seeing that is successful. So again, we're in early days. This is just something that we're just now trialing, but there is definitely this connection with using it on the body and having this greater, far-reaching effect, whether it be the energy systems like you're mentioning, or literally just, developing.
You had something earlier that we're spending a lot of time. We're not talking about it a whole lot because people feel uncomfortable with it. But we noticed in our first non-union study, people who had, for instance, they might have had bilateral tibial non-unions. And by treating one non-union, we actually saw improvement in the other. So there is a systemic effect. It's always been underrelated, underreported. And we're really starting to focus on that. There's some really cool stuff we're doing just by treating the hands and blood, quite frankly. There's just that's the next frontier is the systemic effect of this. It's not localized. You hit on it with the lasers too. That might be the most important thing that we do, our ability through mechanotransduction to affect this systemic inflammation, for instance, just by treating a localized inflammation. It's really underreported, and we're spending a lot of time and money researching that right now.
Absolutely. Well, so another thing I was going to mention was my father-in-law actually had what appears to have been a gout flare, right? And he's never had this before. I went through all the differentials. We had, x-rays. I've tried to rule out everything that I can, but just in the middle of the night, his ankle just lit up, just started hurting. Like he said, it was like more pain. He's not he's a really tough guy. Pain doesn't really affect him. So for him to be hobbling and really complaining about this, it was a big deal. And so it does appear like it was most likely a gout flare. And so the very next day, we used the Softwave and lasers on him. That literally just knocked it out. I'm talking knocked it out.
Now, I love the combination. It's really, like I said, 10 years ago, I'd like to argue with you, but now every modality out there, it's the combination is really, nothing's perfect, but the combination of 1, 2, or 3 really is important for folks not to argue among each other, to say that every one of these technologies is beneficial. And when you combine them with something else, it's 1 + 1 = 3, in my experience.
Absolutely. Yes, absolutely. 100%.
Hey, I want to go back one thing. Promise me, when you say it's your back, typically people say it's the back pain. It's not the lumbosacral spine so much as the SI joints that are usually highly inflamed. And you'll find, and it's funny, it's not the same spot every time. But when you find one, most people say, oh, I have this horrible back pain just on the right side. And you go over to the lumbosacral spine, it doesn't really hurt. But when you go to one SI joint that they say it hurts, the flank, it lights up like a firecracker. It's very uncomfortable for a bit, and then the pain goes away pretty quickly. But what they don't realize, it's always bilateral. When you go to the other side and do that, they're going to say, oh, no, it doesn't hurt over there, but it does hurt over there. So you have to treat both sides. But more importantly, though, that especially if you're a runner, I will promise you that in addition to treating the SIs, roll over and treat essentially the hips, especially the abductors. Just go over the entire area, and that'll be 3 times more painful than your SI joint.
Yikes.
And it leads to much more longer lasting pain relief in the back. It's the hips that are causing, the vast majority of the time, especially in women, it's the hips that are causing the back pain. It presents in the back and also the pelvic floor. But as an aside, I just had one of the most prominent urologists get up in front of the AUA. He's probably the expert on orcalgia, which is men's testicular pain. And because of what I just told him about sports medicine, about how the hips and the lower back present to the pelvic floor, he is now treating orcalgia by treating inflamed hips and lower back. Okay, so that's all he does. He doesn't even treat the genitalia, no farm anymore. But just by treating hips and back, and the women have the same, a condition called PGAD, persistent genitalia arousal disorder, a high incidence of suicide. Just by treating the inflamed hips and back, you can modulate that, make it feel so much better. Long story short, you'll get more benefit for your running by treating your hips, especially the abductors. You'll see it's incredibly painful, but it presents, you think it's your back, but you have to treat your hips to get the full benefit and a much longer lasting, because you're just treating the symptoms in the back that's being referred most times from the hips. The other thing I'll give, 90% of the time, if somebody walks into my office and says they have horrible neck pain, unless they've had a car wreck or something like that, it's coming from their shoulders. And physical therapists understand that's the whole thing about referred pain. That's probably what we do best. Anybody can be good with Softwaves in a day or two just by treating the pain directly. But if it comes back, you've missed spots, and there's being trigger points or fascia that's been damaged somewhere else. And all the physical therapists on this is being referred from somewhere else. But for your personal biohacking, I promise treating your hips is going to be more beneficial than treating your back.
Perfect. Okay. Well, I will do that. I have not gotten into the hips, so that is definitely
hurt. I'm warning you.
So just to clarify, right? Because we've talked about how this is not painful. The Softwave you have the ability to turn the energy down, yes. So it's not like...
The key is you diagnose on high, you find it. Because if you just go over at real low energy, you won't find the spot, okay? Because you have to have that depth of penetration. So I dial up to mid-range. I say diagnose on high, treat as the patient allows. And so I'll find it quickly at level 10 or 11 and hit me, oh, boy, that hurts. And the neatest thing is I can be a quarter inch away from your inflamed spot, and it doesn't hurt at all. You move that quarter inch and you go, whoa. And then, okay, well, you say, I'm not here to hurt you, okay? We found the spot. Let's turn it down to where it's tolerable. They go, oh, that's fine. I can feel it. But I also have to tell them that if you can't feel it, it's not helping. And the more pain you can tolerate, the quicker and better you're going to heal. Yeah. And so they know if they have control, they say, well, that feels good. And then you treat for 100 shocks, go up level one, but diagnose on high, treat as the patient allows you. But I meant to correct you too. It's not painless, but it's a whole lot less painful compared to anybody else. And we can turn it all the way down. It doesn't have to hurt at all, but it might take 4 or 5 treatments instead of 1 or 2 treatments if the patient will allow you that it's going to be uncomfortable. And the more discomfort they accept, the better and faster they're going to heal. But your hips, the first time you go over it, you can go, whoa. And then now you found it, turn it way down, work it back up slowly, and you'll be very comfortable. But we have to find the spot by finding the pain. That's the only difference. Right. You have it at a level to find the pain, because the neatest thing about this technology, I've had hundreds of people walk in with MRIs and say, I've been to Mayo Clinic, and here's this MRIs, 3 different ones, and can you fix that? I go, it's probably not that spot. And so I'll put the probe on that spot. Doesn't hurt at all, but I'll go 3 inches away on a trigger point, and they'll go, wow. And when that trigger point's healed, the pain in your neck, for instance, goes away. Yeah. It's a very important concept about referred pain, and physical therapists are the best at this. It's so intuitive to them. They know about it. They always know about it. You're all just not so much. They have a hard time telling their patient that I'm getting rid of your testicular pain by treating your lumbosacral spine. Right. Yeah. But they're coming around.
That's interesting. I will say I had a CRPS patient, so chronic regional pain syndrome. Yep. It was mostly situated in her lower extremity. It was full body, but it was mostly lower extremities. And she did actually have a lot of like pelvic inflammatory things. She would have pain radiating through her perineum into the genitalia, et cetera. And so I remember you telling me some of this, right? And so we treated her with this, and she was in for a little bit, and we've made progress on her before, and she had come back. And I worked on her sacral plexus area, so the sacrum, the pelvis, the hips. I did do both legs. I didn't go into the genital area. I mean, that's, we didn't.
That's the amazing thing. You don't have to.
That's And so she came back the next day, like elated. She said she woke up for the first time with 0 pain. And then on an average for that day, her pain was down by about 50%. And that was just after 1 treatment. And that was CRPS. I'm not talking about just like, someone that just has random pain. I'm talking about years and years and years of suffering. That's what I'm talking about here. So it's amazing technology. And with that little segue. I mean, we've talked about all these different areas of the body. I mean, I'll say it this way. In your opinion, what has been the most fascinating, area of the body or thing that you've been like, oh, wow, I didn't realize that this could help this area of the body. Now let's go look at that. I mean, I know there was a paper on cardio that came out. I know there's a lot of urology, sexual health, all these things. Like, what's the most exciting in your mind?
Well, the frustrating here, we are guilty as charged, is that when you understand the mechanisms of action, okay, if I talk to a urologist, he wants to talk about heart disease. Every heart surgeon wants to talk about erectile dysfunction. I mean, it's hard to stay focused, and we're sort of unfocused parallel waves. But what I try to focus on those few seconds a day is when we talk about the mechanisms of action that are proven, and they're proven at the highest level. I mean, there's randomized controlled data on every mechanism of action. One, the first is the stem cells. Tom Liu at UCSF and many others have proved that the mitochondria and the resident stem cells light up within seconds, and they go to work. Two, there's stem cell migration within hours, and differentiation within days. So the stem cell mechanism, it's incredible, ultimately leading to a 300% improvement in blood supply at 12 weeks, small, medium, and large vessels in the ischemic heart. Okay, that's the most important mechanism. We bring long-term blood supply, new blood vessels, small, medium, and large. The second, and the most talked about, especially for pain, is our ability to modulate inflammation. Okay, we used to say for years we're reducing inflammation, but that's not true, because when we treat a non-healing fracture, somebody can have a 30-year-old non-healing fracture, they have no inflammation.
Right.
Inflammation's not bad, but too much is of a good thing, is a bad thing. So we're actually on a non-healing fracture patient, we're wanting to turn on the inflammatory pumps. We've actually had a patient who had a 30-year non-healing fracture in his tibia. We treated that one day and turning on the inflammatory pumps, but because he'd been on crutches for years and years, his shoulders were horribly inflamed. We treated them, and then the shoulders were turning down the inflammatory pump. So our ability to modulate inflammation is the key buzzword. We can turn it up or down. It's a smart response. And then third most important thing is we're usually antibacterial, anti-infectious. We are treating infected knee implants, hip implants. At Piedmont Hospital, we're treating, there was a small series where they treated infected LVADs, left ventricular assist devices.
Mm-hmm.
And if you can't, this was after they failed everything else. And if we hadn't got rid of the infection, they would have had to remove that. And that's catastrophic, because that's keeping the patient alive.
Right.
So our ability to destroy bacteria might be the most important thing we do. And we've proven it three different ways. One, a ton of papers showing how we disrupt the biofilms mechanically, so the body's own blood supply can get there. Two, there's a peptide called LL37, which upregulated several 100%. That's the most antibacterial peptide. It activates in mass with shockwaves. But most importantly, once again, is our ability to immediately bring blood supply, so your body can bring its helper cells, and permanently at 12 weeks, 300% improvement. Blood supply probably is the most important thing that we do. But knowing these three mechanisms is so hard. I'm going to challenge you. Name an indication that would not benefit either from stem cell response, modulation of inflammation, or anti-infectious bacteria.
Right.
That's where we get in trouble, because if people said, "Does it work?" I go, "Well, yeah." I can't. It's not FDA approved. However, there's a half dozen papers for it. And why would it not work? Because most importantly, when you said the most exciting thing is, this study took over almost 25 years. The European Heart Journal, this came out, is we've been doing this for years and years with the Austrian healthcare system, but finally got published. It should have got published in Lancet. One editor pushed back. Everybody else said yes, but Lancet turned it down by one vote. But it went to the European Heart Journal. When they cracked the chest during bypass grafting, if you've had a heart attack, you have a scar on your heart. Okay, and your ejection fraction, we were treating only patients with like 25, on average, I think it was 28 was the ejection, which is very low.
So at 28% ejection fraction, you're actually in heart failure, right?
Yeah, that you're on oxygen to get up and downstairs. So
right.
You can't walk 100 yards. It's your quality of life is shot.
Right. And so what were the results after applying Softwave to these people?
Well, the Europeans, because they're not good salesmen, they tell everybody that they raised the ejection fraction an average of 12 points. Okay, 11 if you take the most conservative. And that just doesn't sound very good. Okay, but when you take 11 over 20, it actually was 38 points. Okay, so your ejection, and that's a single treatment at 12 weeks. The ejection fraction, and the different they took. BBC did a 30-minute special on us. They interviewed the patient a year after his treatment, and he was running in a 10K race. The BBC interviewer, how's it help your heart? And he's sort of looking at her.
Wow.
I'm running a 10K. What do you think?
That's
so it's
amazing.
Dramatic improvement in lifestyle. But the most important part that they did not even publish, which really is the most exciting thing about our technology, is they never could have done it here, but in human clinical patients, in German, Austrians, when they cracked the chest, they took a biopsy of the ischemic heart immediately when they opened you up. Then they applied 15-minute Softwave treatment. Then they did it immediately a biopsy again. And they were able to show all the known genes responsible for tissue regeneration lit up like firecrackers. We were able to turn on all the genes responsible for generation in a matter of 15 minutes. And that's why this is really biohacking. We are now having a genetic response. We are turning it on and off the genes responsible for tissue regeneration.
Wow.
And that's why we're so excited. This one study single-handedly, because also if you're now treating the energy level I use are like 0.37 millijoules in the heart focused with our old focus probe, but that's just because the study started before we knew any better that unfocused worked better. But they had to continue the same energy settings or they couldn't use the data because it lasted over 20 years. But they showed even with high energy focused shocks directly on the beating heart, we were able to have this huge, improvement in the ejection fraction as well as what you see with the genes being responsible for generation lighting up. And the data was accepted and peer reviewed showing that the 300% improvement in blood supply in the ischemic heart at 12 weeks.
That's just amazing. And so a lot of...
So I'm excited about everything. What does not benefit? Because leading into your segue, one, we don't have any FDA clearance for the brain, but my number one most exciting thing that I'm spending my time on is the brain.
Yes.
And Alzheimer's, dementia, Parkinson's, because we don't understand that, but we know we modulate inflammation. We have 300% improvement in blood supply. Another example I give, we have pictures of people who've had tummy tuck surgeries 10 years ago. It's a nice red and raised scar. We treat half and it's 80% reduced at 12 weeks. So we can remodel scarring, even old scars, okay?
Yeah.
And we have an amazing effect on the lymphatic system we've proven, or the glymphatics as they're in the brain. And a lot of people are starting to think it's the glymphatics that are, responsible, that you're not draining all the toxins out of the brain.
Right.
So any of the theoretical known causes of all these brain indications, we've proven that we can be very, very useful for managing each of those. So why would you not try that? So we're going to spend the vast majority of our time and research budget exploring the human brain here going forward based
Perfect.
on all that we know about the underlying mechanisms of action.
Yes. And that's obviously what really excites me. And that's where we've been using the Softwave quite a bit, honestly, more than anywhere else as far as like where we're applying it on the body. We're doing it on the brain and we're doing it for brain rehab, right? So we're actually folding this into our neurosolution methodology where we're actually using Softwave, even with our V-cell procedure. Sure, for the functional medicine side, we're using it to increase stem cells and then to actually use the Softwave after the procedure as well. And we're seeing better results that way too.
Yeah, we love the combination with stem cells that's the most exciting thing because the knock on stem cells is, I'm just making this number. If you inject a couple million in the ischemic heart probably is the most studied stem cell model ever. And they showed a nice improvement over time, but the knock on them is most studies will show is the stem cells don't know to stay there. So you have to put so many in to get enough to have an effect. Mm-hmm. But if you do Softwaves first, you're sending out signals saying, come here, help me. Essentially, stem cell attractants are produced. So not only for your own body stem cells go there, that as you age, you have less and less, but any of the other biologics that if you injections or however, they will know to home on that device. So the combination of stem cell therapy or PRP therapy, any biologic plus Shockwave is amazing. Once again, 1 + 1, I used to say 3, but I think it's 13 or 30. I mean, the combination is amazing introducing biologic with Shockwave because of our signaling effect that we can cause the pathologic tissue to say, because after 12 weeks, the body thinks it's healed itself.
Right.
So if you're dealing with, chronic pathological tissue, the Softwave say, hey, I'm injured, come here now. So that's a big advantage in combining these technologies that we're really excited about. Absolutely.
And I think, and we haven't talked about this, but a big thing that I think Softwave is helping with, just like photobiomodulation, a big focus of mine is on mitochondrial heteroplasmy. And heteroplasmy is when the respiratory chain in the mitochondria, so you have the electron transport chain complexes 1, 2, 3, 4, and then you have the ATP synthase pump. But basically, as they swell, as they get further apart, you lose the efficiency of how those electrons go through the electron transport chain to produce your exclusion zone water and ATP. So
Wow.
I do believe, because how else could you be affecting all of these genes? How else could you, because that's where my mind is going, is that, okay, if we're really having an influence on the genetics, epigenetics, if we're really accelerating how something heals, if we're really doing that, doesn't matter the modality, but specifically with Softwave and with my background, photobiomodulation, we have to be influencing the mitochondria, but specifically the story about mitochondrial heteroplasmy, which ultimately I believe is where, healthcare, innovative healing strategies are going. And I think that that's going to probably be a conversation maybe your researchers will get into. Maybe they already are, I don't know. But I think that's a big part, right? I believe that you're having a very positive influence on mitochondria, mitochondrial DNA, and the respiratory chain in and of itself.
Tom Liu would agree with you. He's spending a lot of time at UCSF on that in his research, and that's all way over my pay grade. But I do want to send you 2 pictures. Really, the first pictures that influenced me back in the late 2000s, like I guess 2008, 9. We got pictures of, you can fluoresce stain mitochondria. Mm-hmm. And they got picture before and after, immediately before and immediately after shockwaves, and under fluorescent, and they just light up.
Nice.
Just the mitochondria just light up.
Perfect.
It's just, when you have that screen, if you had to have one poster as what is representative of the power of this technology, the mitochondria off, the mitochondria on immediately after treatment. And we didn't pay any attention to that for 20 some years.
Right.
But now we're going back to that. And your conversation really makes me want to go back to that. And Tom Liu is encouraging us to go back to that, something we discovered in the early, mid 2000s, that we should have been focusing on that all along. And we haven't been. So once again, we're probably going to rewrite the known mechanisms of action to include that, because that's brand new out there that I think you know more about it than I do. But just based on your other research from laser,
right.
That's new to us.
Well, I believe there's a lot to explore there, and I would love to see the information you just mentioned. That's really exciting, just to be honest, because I mean that's really showing that, hey, we're getting down to the subatomic level of healing, right? If you can affect heteroplasmy rates, which ultimately I would argue that this is even a big cause of autism and neurodevelopmental disorders, a big cause of mental health issues, but basically, as our heteroplasmy rates is increasing, we're giving birth to children with this higher heteroplasmy rate. And ultimately, at some point, there's going to be the straw that breaks the camel's back, and you're going to develop this, let's call it dysfunction, disease state, whatever you want to call it, this imbalance. So if we can find a way to reverse that,
that's what
huge.
We're so excited about. You hit the magic word is balance. I think that's all we really do is bring things back into balance,
right,
at a certain level. And how could something on the cellular level? I mean, as a simpleton, what you were just saying, we have to affect it on the cellular level. We have to on the subatomic. I mean, you can't have healing one without the other, I don't think.
Yeah.
But it's so hard to validate. That's the challenge.
Yes, it is, because you're talking about quantum physics at that point.
There's something going on.
Yeah, absolutely. Well,
I would have told you, of course, the genes were turning on. How else can you get original tissue? I mean, pink healthy they had to turn on.
Exactly. Well, man, this is just an amazing. I mean, we could talk for another couple of hours. I think. I mean, you're just a wealth of information. But before we kind of wrap things up, is there anything else that you'd like to communicate to the world? Is there anything that we didn't touch on that you'd really like to tell the audience?
No, it's the most important thing we do is patients that have hope. I mean, chronic pain is horrible, wears people down. And just knowing that there's something out there, don't give up.
Yeah, absolutely. Well, I know there's going to be a lot of people listening that are thinking, man, whether they're a provider, there's someone at home suffering, something like that, they're going to be thinking, I got to get this technology.
That's the challenge. And I get in trouble every day because people want to call me and say, does it work for it? I say, first thing, well, it's not FDA approved for this. And how I answer it is, if it was my daughter or son, I would do it. I do it myself. I treat my forehead and basic skull. I've had 20 concussions in my life. So we're doing some concussion research. It makes all the sense in the world. My dad passed because he had multiple concussions. So it going back, it's safe. However, I still can't make certain claims.
Yeah.
But why not try it? We're doing hospice, but how we do it with all the time under compassionate use, when they've given up all other hope, why not try?
Yeah.
And more often than not, you go, wow.
Right. Yeah.
and then we got to say, well, gosh, how do we not tell people about this?
Exactly.
It's a challenge. The FDA's, if they have a jail, I'm going to end up there one day, I imagine. It's hard to share, knowing as safe as it is, it's hard not to share the story.
Yeah.
And now that our company's so valuable, it didn't used to be, so I didn't mind. I had nothing to lose, but now all of a sudden I have lots of shareholders, and
yes.
so I have to be much more careful. But it's
right.
really
well,
and you've seen it yourself. I mean, you're comfortable after this reading. You saw that it's safe. You very quickly got beyond the concern factor, and really the only risk is that I must tell anybody, we're not going to cause any injury. However, but when you're treating somebody with Alzheimer's, they're not healthy people, okay?
Right.
And I've had this happen. I've had an amazing recovery on a friend and family. They had been incommunicative for years. They had an amazing 90-day recovery, and then they for some unforeseen reason they had a seizure, okay?
Mm-hmm.
And if they were, and I don't have any research to show that it doesn't cause seizures and Alzheimer's pain. I don't have it. There's never been an effect that's caused seizures anywhere. However, because of lawyers and things like that, you just have to be cautious, because these are unhealthy people. If coincidentally something happens to them 6 months after you've done a series of treatments, and we don't have any randomized control papers, that it's intimidating, because you have to protect yourself. So you have to have other releases, the compassionate use, because it's so tempting to do something so easy and so beneficial. But make sure you cross your T's and dot your I's and protect yourself.
Right. And yes, you're right. I mean, I can speak a little differently because FDA is not monitoring my scope of practice. They're more. Yeah, exactly. So I can be here saying, look, we're treating it, we're doing the brain, we're doing this, that, and the other. That's off-label use that defers to scope of practice, et cetera. Totally different. But I know that, people are going to be searching for providers that are using this technology. I believe you have a list of providers on your website.
Yeah, if you just type in, it's a provider search, upper right-hand corner, and
cool.
Top 10 closest providers. But if you have any doubts, call me, because some indications should not be handled by certain specialties and some
right.
others. So I know those folks who are doing things outside the box. I'd be happy to point you in the right direction.
Perfect. Yeah. And then, we specialize in complex neurological disorders, like the really tough, like difficult things. And that's what, myself, Dr. Madeira, like that's what we do. So, but then there's going to be providers, there's going to be lay people that want to purchase this unit after listening. So you said we can have a referral code. We'll put it in the notes. So we'll put that in the show notes for all those people that want to go out and acquire this amazing technology, which I fully support. I think is.
Yeah. And just give them my phone number so it doesn't get confused in the pipeline. So I would
okay.
be at 404-402-6844. And this
that's bold. You're bold giving your phone number out.
No, I'm good. That's what I do. I hate. I'm the worst manager in the world. All I do is like talking to people.
Oh my goodness. We may have to edit that out, my friend.
Some of those famous people in the world own our machine. And
yeah.
we don't talk about it because it's 7 million men have been treated for erectile dysfunction. Okay. So it works. And if you're wealthy, you don't want to go stand in the office and everybody stare at you. So it's,
right.
it's not that expensive. And after a year, you can resell it for about 90% of your value if you want to, but
I totally,
you're going to fall in love with it. And
I totally understand that. Just to be honest, I mean, so you told me about the studies with orcalgia and testicular pain and all these types of things. So, I mean, just to get a little bit personal here. So I actually have some orcalgia. I have a varicocele in the left testicle, right? So I've got this, it's basically a varicose vein that causes pain and whatnot. They've said, hey, we need to operate and all this kind of stuff. And I'm just like, no, I don't want to do that. So I will say, I've used it, I guess, 3 times now on the testicles, and the pain is gone. Like literally the pain is gone.
The problem, it comes back though. It does in a short-term basis for testicular pain directly. We did that for years. It'd make pain go away. Nothing else could other than meds. Okay.
Yeah.
And so people have been doing it. However, it would come back. That's when we discovered the lumbosacral spine, and that would be gone for longer. Then it'd come back. That's when we discovered the hips, especially where the IT band joins, and then also the abductors. And just treat the entire hip plexus,
Yeah.
and you'll find the pain. When it goes away, your pelvic floor relaxes, the pelvic pain goes away. We're doing all the vestibulodynias, we're doing all the women's painful intercourse, stress incontinence. The women's pelvic health is what we're most excited about because nobody's spending any time or money on it except us.
Right. Well, I wonder if
there's
maybe
been 10,000 machines sold for men's sex health and like 10 for women's.
Oh, wow.
It's horrible.
Wow. Yeah, I didn't realize. Well, maybe that's why my pain isn't
Do
coming back.
Your hips are going to be. It wouldn't surprise me that it's just if you're a runner, there's a huge correlation between activity and the more you abuse yourself physically, the more likely you are to have arthralgia. So
Right.
do your hips. That might be even more beneficial long term. Treat it directly as you have.
Yeah.
But also, you would notice if you were to take a testosterone test at 72 hours in like 2 weeks, it temporarily goes up when you treat your testicles.
Well,
And funny enough, it's actually painless because that's the stem cell response. You're not treating an inflamed area typically. If it does hurt, you stop. But like when you're treating, it's totally painless. When you treat any acute injury, it really hurts for a minute until you turn the machine down and work your way up slowly. When you find it, you first, oh, that hurts, but you turn the machine down, work up slowly. But
Right.
there should be no pain when you're for ED and that kind of thing. And the last pitch I'll give, probably the most commercial thing that we do, and it has not even been, it's not reimbursed yet, but when you, for ED, which does have reimbursement code, and most insurance companies are paying now, you're treating the shaft left and right, you're taking the base of the penis left and right, and then you treat the perineum, the whole area. But during the perineum treatment, in the direction of the prostate, thousands of men have reported that if they had frequent nighttime urination, got up 3, 4, 5 times a night, within 24 to 48 hours, it's reduced by at least half. Okay, wow. Because it seems to that's the inflammatory response. It modulates the inflammation immediately. You get a symptomatic relief. And quite frankly, I think more men would rather sleep through the night, and their wives too, not waking them up 4 times a night to go pee,
right,
with an immediate benefit after 1 or 2 treatments instead of 6 or 8 treatments for erectile dysfunction that may or may not, be successful.
Sure.
So the nocturia thing is probably the most commercial thing. We're really pushing that because
that's a big deal
almost immediately. Yeah,
it's a big deal. I mean, that disrupts circadian rhythms and all the things. So
if you don't sleep, everything's affected. But yeah, it's been a pleasure. And if you ever got, anybody got any questions, I'm happy to talk to folks. And once again, I'm not a clinician, but I can point you to somebody way smarter than me that has a whole lot of research. And
I'm going to probably sell a ton more machines for you right now because I'm going to continue the story. I didn't plan on doing this, but I'm just going to go ahead and tell you. So treated the testicular pain, right? So I think I've done it 3 times, and I'm thoroughly convinced. And I asked my wife, I do believe that there's been some hypertrophy, meaning they're bigger. Is that something that you've seen?
No, absolutely. No, I didn't mean to bring that up. No, I treat 80-year-olds all the time. They look, they're amazed. It's regenerative. I mean, the scrotum of an 80-year-old man looks like the scrotum. You see amazing within 6 or 8 weeks. I don't want to say you're not 21, okay, but it's a dramatic appearance. And that's why the market if I had to do all this over again, one, I wouldn't be here because I'd be a billionaire, okay? But one, we started out 20 some years ago trying to do diabetic ulcers against the advice of probably the best wound care guy in the world, said, you're not big enough company, you're never going to do it. He was right, okay? And we almost bankrupted ourselves trying to do it. But what we should have done is gone aesthetics, because our competitor was a company called Soliton from Texas. They just sold the AbbVie, and all they do is treat cellulite, not cellulitis, cellulite, and also they accelerate when you do tattoo removal. It's a burn, okay? You can do tattoo removal more efficiently, less painfully. That's all they did, and they sold for $550 million cash.
Goodness gracious.
Okay? And we all know we can do fine wrinkles. We just don't have the probe for it. We all know that it's anti-aging. I mean, of course it works on skin.
Yeah.
But we've made the mistakes of proving it on heart and brain when the most obvious thing in the world, when people pay cash, which we should have just focused on that originally, would be the aesthetics applications of this. And so, yes, I've had dozens of men tell me that when they've treated their testicles, it's a dramatic appearance in a matter of 6 to 12 weeks difference.
Yeah. Well, I can attest to it. I did not expect that. And I was like, wow, okay, that's interesting. That was a very
well, not to really mess you up, though. If you're an 80-year-old man, and I do have some 80-year-olds doing this for ED, the first thing they report is at 6 weeks, the girth and the size, it's not bigger than it was, but it's bigger than it is. I mean,
right.
You don't go to it in 21, but it is new blood supply. What
Sure.
doesn't benefit from a 300% improvement in blood supply?
Exactly.
So that's the other thing. The anecdote I wanted to share on this that really makes us unique from some of your notes that you gave me. We have a database in Austria. We still don't have FDA approval for non-healing fractures because FDA still considers it class 3, which is nuts, okay? Because it's the safest thing to do. We have the best research on that. And about 5 to 10,000 cases in this non-healing database in Austria, we've treated with Shockwaves, and we have 85% success with a single treatment at 12 weeks. If you had a 30-year non-union or a 6-month non-union, it's all the same. It's also the same if you're an 85-year-old smoker or an 18-year-old athlete. So it's 85-year-olds have the capacity to regenerate. I can give you two phone numbers, 2 90-year-olds who've been treating their, and they will tell you it's not like it was, but the appearance changes, including, why would you not have the same effect on the shaft as you did on the scrotum?
Sure.
And you would. And then finally, the proof of stem cells, the worst case I've ever seen, I can't even remember, it's essentially gangrene of the testicles.
Yikes.
Urologists would know who it is. Okay, you don't see a whole lot of the cases, but the European urologist said, I don't believe this stuff. And our doctor said, what's the worst case that you've ever seen in your life? And it's called something gangrene. And before, it's horrible. You can only imagine. But they did the whole series of Shockwaves. After about 12 weeks, it came back, and the tissue had been totally necrotic. Okay, this not only on the shaft but on the testicles. When they came back, the pictures are on the scrotum, you have the wrinkly skin of the scrotum perfectly healthy, and on the shaft, you have that fine skin perfectly healthy. So, I mean, if it's not stem cells, what else could it be? How could you take necrotic tissue and totally pink healthy? There's a different skin textures and types. So that's what made this urologist a believer. He came back. He's now doing it for everything. We're doing infected penile implants now.
Jeez.
Nobody's ever done that because now you have to take them out, which is horrific for the patient. If you had a penile implant and it gets infected, and then you have to take it out, it's horrible. So now they're treating those in situ and having dramatically improvement. They don't have to take them out, just like they're doing infected LVADs and hip implants.
Sure.
So the antibacterial part of this is hugely exciting, and we haven't talked about that, and something else we'll talk about another time, though.
That's amazing.
Well, you got me on my soapbox. I'm excited. So
absolutely. I mean, that's why I wanted to talk with you. You're passionate about it. You want to help people. Like this is just amazing. So
do not try it on hair growth.
For those of you not looking at the video, he says that because he does not have any hair on his head. Oh man. Well, John Warlick, I really do appreciate this conversation. I appreciate everything that you're bringing to the world. You're really helping people that have been suffering immensely. And I've seen it firsthand, people suffering, and literally the suffering stops in a very, very short period of time. But it's not just symptomatic. It is restorative, regenerative.
It's fun. And next time there's a paper, it's about to be published about extending the length of the telomeres under the influence of shockwave.
Excellent.
That's a soon to be published paper for anti-aging. When you said the biohack thing, I thought that might be useful.
That's amazing.
I'll have that publication here next time we talk. That should be really exciting.
Perfect.
Thank you. And like I said, if I'd done a better job, the world would be a better place 10 years ago, but I guess I'm lazy. So I started this in 2004. It should not have been a 20-year journey.
Right.
But the FDA, when we started, we were all class 2. Everything I talked about was class 2. Kidney stone treatment, class 2, because we got lobbied against. In 2008, when we finally submitted our class 2 paper, thinking we'd get a rubber stamp, they said, policies change, you're now class 3. There's only 30 to 40 FDA approvals each year.
Yeah.
And they're almost always by billion-dollar companies, never by small companies like us. So as soon as this became class 3, it became a 20-year journey instead of a 3-year journey.
Yeah,
so
I totally understand that.
They finally are reclassifying, and it's exciting time for Shockwave. My 2 competitors have there's a $13 billion sale to J&J and a $500 million to AbbVie, the Swiss pharma company. So hopefully, the resources will come our way, and everything we just talked about a few years from now will be standard of care.
Absolutely. I thoroughly believe that will come to fruition. So
I can't wait to come meet you down in Texas. So I'd still want to come have a training day with you.
Yeah, man. Can't wait. So, well, everyone, if you're listening and you think that this can help someone that you love or know that is suffering, please share this information. In the meantime, thank you again for listening, and we will talk to you next time. John, thank you so much.
Yeah, and do not send pictures. You should see all the pictures I get.
Oh my gosh, I can second that notion. Oh man,
a little text is fine. I don't need the pictures.
Right.
All right. Thanks, everybody.
Thank you.
Appreciate
All right.
it.
We hope today's episode has inspired you to take that next step toward your best self. Remember, the path to longevity is paved with small, daily decisions. Your journey is unique, and every step, every choice, brings you closer to your ultimate vision of a healthier, happier life. For more insights, tips, and resources, visit drbrandоncrawford.com.